We are in a very nice community area, but completely landlocked. There was no room for expansion, and the town of Ridgewood, I would say they probably have a love-hate relationship with us. They love having the hospital there. They love that it's readily accessible and available to them. However, they do not want construction vehicles around. They do not want to deal with the traffic and all the rest of it. So over the course of a period of time, Valley was, just to give you an idea of the time perspective, Valley was acquiring property in Paramus, New Jersey. And in January of 2017, they did announce that the new hospital was going to be built. In early 2018, we did receive our certificate of need through the state of New Jersey, and we began our lean design process for the new hospital. So at this point, I'm still peripherally involved in my role within nursing informatics, not full-fledged at this point in time. We had our groundbreaking, in late 2019, and as I mentioned earlier, it was in early 2020 that I began my new position. At the same time, as we all know, COVID hit, and the problem, there are many problems obviously with COVID, but the problem for us is that construction continued. Construction did not stop. The hospital had done a lot of pre-planning and purchasing of materials and supplies, so those construction workers and trades, different trades were out there every day continuing to move that construction forward. But essentially, internally, we stopped all of our planning. We were focused on the pandemic. So in an attempt to reset, we did start it up in 21 with some design meetings again, different user group meetings, and as recent as November of last year, contracted with our transition and activation partner that is also going to help with that smooth transition and move into the new campus. We expect our department, we expect to receive our either temporary or permanent CO from the town of Paramus in about July of 2023. Expect or are planning for a Department of Health survey in September of 2023 and our move-in in early December. Nothing better than a move-in around the holidays, the cold weather, and Bergen County traffic. So we'll cope. We'll cope. Oops. Okay, just to give you an idea of some of the differences between our current and future campus. So you can see that we have today approximately 550,000 square feet, and we're not quite doubling it, but pretty close to doubling it at about 900,000 square feet. Today we have 8 elevators. I would say on an average daily basis, probably one of them is not working. And we're moving to a new hospital that will have, I'm astounded by this, 23 elevators. The elevators will have set purposes, obviously visitor-specific elevators, and then elevators that are designated for staff, patient movement, supplies, etc. We today, because we are an older hospital, have a combination of both semi-private and private rooms. And in the new hospital, we are going to all private rooms, which I don't think anybody would build a new hospital today without going in that direction. And we expect that we're planning that all of those rooms will be standardized. So right now, I kind of equate our rooms to being like hotel-like, where, on one side the head's here, and on the next room the head abuts the previous. In these rooms, when you walk in, everything will be laid out the same. It won't matter if it's a critical care room, if it's a med-surg room, if it's a mother, baby, or pediatric room. They are all the same size and the same orientation. We were also able to take advantage of some of the lessons learned in respect to COVID at the point in time we were in with construction. So a couple of changes that we rapidly made were to modify all the rooms or the head wall and the head wall gases in the room to all serve as a critical care room. Heaven forbid the potential exists in the future to do that. We also took the opportunity to look at the doors in the patient rooms. And the doors, for the most part, outside of critical care, were solid doors. So instead, through different user groups and interactions with our clinical staff, we made a decision to put a window in those doors. We learned about our lack of visibility during COVID, or that line of sight with the patients. So we put a window in every door, and the window has an inline blind that's adjusted either external or internal to the room. I'm sorry about the glasses here. We today have many more centrally located nurse stations, or I should say centralized nurse stations, where the staff moves to the nurse stations after they've done their care, and they're documenting more at the nurse station. So here we have small nurse stations, and certainly that will be a major adjustment for the staff and part of the workflow design that we do with them to look at pushing them out and making it a decentralized nurse station. And we did put documentation stations throughout the unit to accomplish that. Today we have an open NICU. We essentially have two large bays, and in the future looking at single private rooms. So we're really going to rock their world as well. I think now the way they work is if they're caring for that baby and they need some help, they can probably just look up and make eye contact with someone, and the eyes say it all. So this will be very different for them as well. We're also looking at combining our perioperative and procedural services. So today we have a separate track of patients that are perioperative oriented, and a separate track of patients that are going in through our cath lab and EP areas, and that area is going to be combined. So that cath lab and EP area will be one specialized and called out as specialized, but it will be within that operating area and essentially behind that red line. So a lot of change for them as well. And, as far as our access into the hospital, right now we have a single point of entrance, a traditional lobby where our patients and visitors come in, emergency room aside. Here we're going to manage two locations. So there'll be a central drop-off, so to speak, area, and then parking on the second floor where, again, we'll have another stream of visitors and patients through that area. It was also important to us that we looked into some staff respite and rest areas. So we do have, what did I write there? I couldn't remember the number. 12, what we call Zen dens or lactation rooms, strategically located throughout the hospital as well. Similar to nursing informatics, what I have found in this role is that we deal on a daily basis, or I deal on a daily basis, just as I'm sure you do, with your internal and your external stakeholders. So, internally you're dealing with your clinical staff, ancillary staff, administrative staff, providers. I also noted there the PFAC. We have a very robust Patient Family Advisory Council. So it was important to us to include them as we moved along. They came in, they sat in the chairs that we were planning for the patient in the patient rooms. They looked at the furniture that we were selecting. They were also involved with technology decisions in reference to those technology solutions that the patient was going to interact with. On the external side, we are dealing on a construction basis with what we're calling our owner's representatives. So they are kind of the heavy between the construction companies and all the trades and representing us. We continue to work with our architect, with our medical equipment planners, our transition planners, and of course, a variety of different vendors. Okay, and just to point out here, and instead of putting my glasses back on and forth, let me just pull up my notes. I just want to make sure I don't miss anything. I called out specifically some of those skills relative to project management, change management, operational management, and technology and innovation.